Okay, guys, we're going to talk through the anatomy of doing a kind of a lower lumbar L5 S1 setup with dry needling. So things I might do this for, somebody that comes into your office, script could say low back pain. It might say hip pain. It might say sciatica. It might say piriformis syndrome, trochanteric bursitis or hip bursitis. There could be any number of things that they might come in. Leg pain could, any number of things that might come in on the script, but we're going to assume that we've tested them out and determined that they have an L5-S1 dysfunction with some lateral hip weakness, pain that's running down the back side of the leg there. One thing to notice anatomically here, as we move superior in the lumbar spine, the lamina get progressively more narrow, all the way up to L1, and T12 is really narrow. Early on, at least in the courses that we do, we're only going to teach from L3 down because it's wider. It's a nice, big, thick lamina. One thing when I show patients the model that they get nervous about is that everybody thinks I'm going to stick a needle into their spinal cord. Couple things to note about that. Number one, it's the cauda equina down here. So you're really not going to, there's nothing stable that you're just going to jam a needle into. It's going to kind of weave its way through, if I was even to get to that, which I'll show you why there's almost no possibility to that anyway. Number two is you've got the interspinous ligament here that is a big, thick ligament that is not only meant to help stabilize the spine, but it also protects the spinal cord quite a bit. Our needles are very wispy, and we have a hard time getting through the thoracolumbar fascia, let alone getting all the way down here to that. So, and lastly, the technique is set up, obviously, so we avoid that. So, at any rate, those are questions you'll get from patients. They always want to know if you're going to stick a needle in their spinal cord. I always tell them that's not my goal. So, if I was to do an L5 setup, again, number one, let's just look at the size of the needle. This thing is a tiny little needle, and even though the lamina looks pretty small compared to the size of the needle on there, the size of the needle is tiny. I've got a lot of real estate to work through here with this needle. So when I am going to apply the needle, I'm going to start on the opposite side. So for this person, I'm going to work on their right side. I'm going to L5 and walking my way out off of the spinous process over top of the lamina, and then I separate my fingers out this way. So now I've got blockage on both sides of the spinous process there, where the kind of those danger zones are. Then my needle goes right next to my fingertips there, down to the lamina there. I'm going to drop my needle. There you go. I put it in the spinal cord. So we're going to drop this needle right down onto the lamina, just like that for this person. We want to get all the way to the lamina because that's where the multifidi are, and that's near where the nerve root is. That's what we're looking at trying to affect with our needling and eventually our electrical stimulation. So L5, again, I'm coming out off of the spinous process, and I'm giving myself a small little window to work with, and I'm going right down to the lamina. It takes some practice to be able to get down through the tissues to get in there. The first time you try to put this thing in, you're going to get stuck in the lumbosacral fat or the thoracolumbar fascia, and this thing's going to bend all over the place as you try to get it through. But with a little practice, you get better. So we've got one needle here. Our next needle would be coming down around S1, S2. I would actually get on the right side of the patient for this one, but I'm just going to stay where I am to kind of show you what I'm doing here. There's two different ways you can do this. You can either come straight down to the sacrum, this way here, or I can go a little bit more at an angle this way. The muscle bulk here, as you get into the sacrum, drops a little bit more laterally here. So I try to go more towards the muscle bulk this way. The thing you have to watch there is you've got nerve roots that are coming out there. So we advance that needle very slowly here. So just in case you nick past one of those, you can get away from it quickly, or the patient lets you know fast and you get out of there. It rarely happens, to be honest with you. But I'm gonna generally go a little bit laterally. Some people will teach it more straight down this way. So Again, I've got a needle here on L5. I'm putting a second needle here back towards kind of that S1, S2 area. I'm finding the PSIS, and I'm needling kind of on an oblique angle there, right? Then the other two and I'll show you this on the other model that we're going to pair that with. So we've got our L5, S1. Right there, that's good enough. You could put your electrical stimulation on just with those two, and you're going to affect that lower extremity pain pretty significantly. But if I really want to get the most bang for my buck, I usually will come out to glute medius and minimus out laterally here on the pelvis, and then hit the back of the acetabulum here with for the piriformis. So I'll show you just real quick on here, and then I'll show you a little more in depth on the other model. If you want to get both the glute medius and minimus, you've got to get pretty lateral out here. The minimus kind of has a much more a much smaller attachment area as it comes down towards the hip. The medius is a little bit wider, and of course the max sits over top, right? My piriformis here is going from about S2 to S4, 5-ish over towards the greater trochanter. And we're going to hit that piriformis kind of right on the back of the acetabulum here where it's still fleshy here. If I get too far lateral, we're in tendon. If we're too far medial, we're in no man's land here. So we want to make sure that we're right over top of the acetabulum there. We've got a good, solid, bony backdrop to get to there. Okay, so that's the intro for the lumbar spine.